Strongyloidiasis stercoralis. Strongyloidiasis stercoralis is a human pathogenic parasitic nematode or roundworm causing the disease strongyloidiasis. Strongyloidiasis stercoralis is classified as soil-transmitted helminth, that the primary mode of infection is through contact with soil that is contaminated with free-living larvae. Epidemiology of Strongyloidiasis stercoralis. Strongyloidiasis stercoralis is found worldwide. Strongyloidiasis is known to exist on all continents except for Antarctica, but it is most common in the tropics, subtropics, and in warm temperate regions. The estimated strongyloidiasis prevalence was 8.1% in 2017, which corresponds to 613.9 million people infected with strongyloidiasis. Referring to the WHO regions, the highest number of infected people live in the Southeast Asian region or SEAR. The increasing rate of infection are caused by poor personal hygiene, insufficient drinking water supply, unsatisfactory sanitary, lack of knowledge about the disease in high-risk populations. Life cycle of Strongyloidiasis stercoralis. The life cycle is unique due to its potential for auto-infection and multiplication within the infected host. The parasite shows two distinct life cycles, one within the human body and other free living in the soil. The Strongyloidiasis stercoralis life cycle is complex, alternating between free living and parasitic cycles and involving auto-infection. In the free-living cycle, rhabditiform larvae are passed in the stool of an infected definitive host, develop into either infective filariform larvae, direct development, or free-living adult males and females that mate and produce eggs, from which rhabditiform larvae hatch and eventually become infective filariform larvae. The filariform larvae penetrate the human host skin to initiate the parasitic cycle. This second generation of filariform larvae cannot mature into free-living adults and must find a new host to continue the life cycle. Parasitic cycle. Filariform larvae in contaminated soil penetrate human skin when skin contacts soil and migrate to the small intestine. It has been thought that the L3 larvae migrate via the bloodstream and lymphatic to the lungs, where they are eventually coughed up and swallowed. However, L3 larvae appear capable of migrating to the intestine via alternate routes, for example, through abdominal viscera or connective tissue. In the small intestine, the larvae molt twice and become adult female worms. The females live embedded in the submucosa of the small intestine and produce eggs via parthenogenesis, or parasitic males do not exist, which yield rhabditiform larvae. The rhabditiform larva can either be passed in the stool or can cause auto-infection. Pathogenesis of Strongyloidiasis stercoralis. Light threadworm infections remain asymptomatic. They may persist for years due to auto-infection or reinfection. Heavier infections can cause several forms of disease in humans, such as dermal, pulmonary, enteric, and disseminated disease. Migratory larvae can move through the skin up to 10 mm per hour and cause larval markings characterized by pruritus, dermatitis, eosinophilia, inflammation, and urticaria. Pulmonary migration may cause a mild transient pneumonia and transient pulmonary infiltrates, or Loeffler syndrome. Lesions caused by adult worms generally consist of inflammatory cataracts, and in some cases, they can become severe infections resulting in necrosis, mucosal peeling, bleeding, epigastric pain, and possibly reactive arthritis. Hyperinfection can develop when individuals are stressed or immunocompromised, resulting in the production of large numbers of filariworm larvae. The larva can penetrate the bowel and disseminate, causing colitis, polymicrobial sepsis, pneumonitis, or neurological manifestation such as meningitis and cerebral or cerebellar abscesses. Immune responses of Strongyloides stercoralis. For immunocompetent subject, first, Strongyloides stercoralis filariworm larvae penetrate intact skin and access venous circulation. Second, filariworm larvae reach the lungs, perforate the alveoli, and ascend through the bronchial tree and reach the pharynx, where they are swallowed. Innate immunity. First response against parasite infection. Neutrophils or APC. Macrophages. Complement C3. IgM. Third, filariworm larvae penetrate duodenal mucosa and deposit eggs, which hatch in situ releasing rhabdidiform larvae. Adaptive immunity. T helper 2 type in healthy subjects. Interleukin 4, interleukin 5, and interleukin 13 increase. Eosinophilia. Increase of serum IgE. Increased mast cells. Intestinal goblet cells hyperplasia. Specific IgA. Fourth, rhabdidiform larvae can either be shed with stool or develop into filariworm larvae, penetrate the abdominal mucosa, access venous circulation, and complete autoinfection. Larva killing. Mast cell degranulation, eosinophils, neutrophils, macrophages. Outcome: controlled infection, chronic infection, asymptomatic, oligosymptomatic or symptomatic autoinfection. Low risk of hyperinfection and dissemination. There are several types of immunocompromised subjects, such as alcoholism, corticosteroids, human T-cell lymphomatic virus 1 or HTLV1, malnutrition, HIV.